Hi, my name is Anam Mohammed, and my thesis is as Dr. Edward said. Type 1 and type 2 diabetes are types of diabetes that happen to individuals, and they both share characteristics. Some of the characteristics they share are symptoms of frequent thirst, urination, thirst, blurry vision, and they both require a healthy lifestyle as well as medical supervision. And without medical supervision and a healthy lifestyle, their disease can progress and cause further complications to arise. Now, type 1 diabetes has some characteristics that are juvenile onset. It's autoimmune or genetic cause of disease, and also non-functional pancreas, which causes there to be no insulin produced. But type 2 diabetes is more adult onset, and insulin resistance can be due to obesity or aging, and because it's a partially functional pancreas, which where some insulin is produced. Now, from here on out, my presentation will be focusing on type 2 diabetes, because type 2 diabetes can be done through lifestyle changes as well as reversed with early diagnosis, while type 1 diabetes can't be prevented and can't be reversed. Also, type 1, there's 1.3 million adults diagnosed with type 1 diabetes in the US, while there's 20 times as many adults diagnosed with type 2 diabetes in the US. So, some complications that can occur with diabetes when left untreated or without timely medical care can be stroke, diabetic retinopathy, which can be cataracts or glaucoma, cardiovascular disease, periodontal disease, diabetic nephropathy, diabetic neuropathy, and peripheral vascular disease, and foot damage, which can then lead to amputations of whether it's one toe or all 10 toes or above the knee, below the knee. All of that can be amputated. And in order for the disease to not occur with all these complications, type 2 diabetes has to be managed. And there are home management and there's medical care management. Some managements that can be done at home is a diet, management of your unhealthy weight, regular blood glucose checks, and exercise. And then at the hospitals, regular checkups need to happen with your physician, an endocrinologist, and your optometrist, as well as medication for oral or injectables like this. So, risk factors are associated with type 2 diabetes. There are modifiable risk factors and non-modifiable risk factors. And this can be some modifiable risk factors, so physical inactivity, poor dietary habits, which can then lead to obesity, hypertension, and smoking. Non-modifiable risk factors include family history, race and ethnicity, increasing age, and history of gestational diabetes, and some certain medications. So, the current diabetes prevalence number is increasing, and this figure is showing how the red countries have a high prevalence number, and the country that currently has the lowest. The 5 countries with the highest prevalence number is India, USA, Indonesia, China, and Mexico. And while the diabetes prevalence number is increasing, it's only projected to get worse. And so this figure shows that Africa is projected to have a 134% increase in type 2 diabetes, and Europe is projected to have a 13% increase. But overall, globally, diabetes prevalence is projected to increase without mitigating therapies. So, so what will cause diabetes? So there is a major disconnect that can occur between patients and physicians, and whether the patients know about the medical care that's out there or that's not out there, they're not able to overcome this barrier and get the medical care that they need. And so some factors that is in race and ethnicity play a factor in diabetic prevalence. And this figure represents an age-adjusted estimated prevalence in diagnosed diabetes in the US. And what is seen is that American Indians and Alaska Natives in the US have the highest diabetic prevalence, while the white non-Hispanics have the lowest. Additionally, education is said to be protective against diabetes, and here we have individuals with different levels of education, and from left to right is increasing education, and those that have less than high school education have a higher increase prevalence in diabetes, and those with a more high school education have less. And so what is causing diabetes prevalence to increase? So this image is trying to illustrate that the patients all the way out here and the medical providers out here, there's this huge gap that is occurring between the two. And this gap can be due to many different barriers, but overall this gap is causing patients to have treatment delays, medication delays, and their chronic diseases are getting worse and complications are arising that aren't allowing them to live their best life. So some barriers that are encountered when accessing healthcare is transportation, lack of transportation, not being able to get to their appointments or to their lab work, language, not being able to understand their medical providers, geographic barriers, accessibility for the elderly and the living impaired, income and physician shortages, which then can cause long wait times. My presentation will be focusing on transportation and language. So looking at how lack of transportation can increase diabetic prevalence, we first have to see how adequate transportation can be beneficial. So a patient that has adequate transportation is able to get timely medical care and timely medication access. And they're able to make clinician visits, they're able to get prescriptions and treatments, and they're able to get medication refills. This then allows them to have an improved health outcome, which means they have improved care based on clinical guidelines, appropriate changes to medication regimen, and prevention of chronic disease complications. Now, an individual with a lack of transportation is lacking timely medical care and lacking timely medication access, which is then causing them to have inadequate medical care and exacerbations of chronic disease and unmet medical demands, which is then causing them to have those complications that we discussed earlier. So some ways that we can increase access to healthcare through transit is through a volunteer-based operating model. And so this model would be where the clinic would have specific volunteers whose role is to mainly go and pick up patients and bring them to the clinic and back to where they need to go. But a downfall with this is that volunteers may not be willing to give out rides due to whether it's the gas or they just don't want to really drive. So then another way we can really mitigate this barrier is through public transportation systems and by giving out bus passes or bus cards to patients that allow them to just easily tap and go, so they're able to get on and off at their stops. But with this comes downfall is that bus stops don't always have routes to every single location, like every clinic or every imaging lab or blood lab, because patients are often referred out of clinics. And another solution would be ride sharing, which is where the clinics would try to have patients that live in similar areas ride share to the clinic and back by having their appointments be at around the same time. And lastly is an Uber program. Now, I personally have volunteered at mental health clinics since 2020, and we've often seen transit be a barrier in healthcare, and we received a grant, and we've used that grant to start up an Uber program where we will schedule an Uber for our patients, and the Uber will then go to the patients, whether it's to their work or to their house, pick them up, and then bring them to the clinic. And we'll schedule another one to take them back. And what we've really seen is that this allows the patient-physician satisfaction has really increased since we started the Uber program, because physicians have been able to see their patients on time and have been able to give adequate care to the patients, and the patients also have been able to get back to work on time, so they're not losing any money while waiting in a waiting room, since if they're late to their appointments, they do unfortunately have to wait sometimes. And so due to this Uber program, they're not having to sit in a waiting room and wait for the physicians to be ready for them. Now, there's language is also a barrier that negatively impacts healthcare. And some ways that language can be a barrier is that the length of stay when an interpreter isn't used at admission or discharge can be increased. There can be central blood infections, and there's an increased risk of falls, surgical site infections, and an increased risk of medication management. For example, a patient might not understand how to take their medication, or when to take their medication, or how many times to take their medication, which then can cause adverse reactions or cause more complications to occur. And then due to these negative experiences, often patients don't come back, which then causes a decreased chance of preventive screening and a decreased chance of access to the healthcare system, which also then can cause their disease to either never get diagnosed or it can cause it to get worsened. And as I discussed earlier, diabetes, type 2 diabetes can be reversed when caught early, but if patients aren't coming in for screening, we can't catch it and we can't reverse it. So some ways that we can mitigate linguistic barriers is through telephone and video interpreters. And this is an affordable alternative, and it can be really helpful since it can allow patients to communicate with their physicians. But a problem with this is that it may not encompass all the languages that are out there. And also, it's not as personal since every single time you use the service, a new interpreter comes on every time. And so another way we can mitigate the linguistic barrier is through in-person medical translators. And I personally volunteer as a in-person medical translator at Hope Medical Clinic. And what we've seen is that patients have become more comfortable with a consistent person that they're talking to. And they're able to build a bond with the interpreter and with the physician, and they're able to open up about their specific problems and their concerns rather than they were when we used the video interpreter services. So barriers are really causing health to decrease in diabetic patients and patients overall. And mitigating these barriers can really decrease diabetic prevalence. And this can be done through ample transportation and clear communication. And this can really allow the patient to become a partner in their own healthcare and can really allow the patient to take control of their disease instead of letting the disease control them. And
we have some time for questions.
Yes. So how come you picked diabetes? Why?
So diabetes is a really big problem in my family. My dad has diabetes, and my dad's whole side of his family has diabetes, as well as my mother's side. And during 2021, I actually volunteered with a diabetes prevention program at Hope Clinic, where we really sat down with patients one-on-one and did time-intensive care, give them time-intensive care, and tried to help them change their lifestyle or their dietary habits. And that's just like when the diabetes prevalence really piqued my interest.
It's really great work that you have done, and especially with the Hope Clinic as well. So did you? It sounds like anecdotally, at least, there's a sense that all of these the methods that you suggested are improving outcomes. But has Hope Clinic collected any data on that, or do you any survey data, or anything like that?
We do survey data at the end of their appointments every time they come in, and we try to ask them how has this clinic specifically helped them reduce either going to the emergency care or not getting care at all, and as well as other insecurities that they might be facing. But we haven't really done actual hard data on it was our
or it hasn't been maybe it hasn't been analyzed
No.
yet, some of those data?
It's just
That would be
probably
really cool to see the numbers.
Yeah.
I'm sure that it is really successful, and then you could maybe get more grant funding or something.
Yeah.
I'm curious, so you showed, you had a graph that showed there is a relationship between race and the prevalence of diabetes. Is that, do you think, a genetic relationship, or is it a lifestyle? Or both?
I think it's, the papers I read didn't really go into too much detail, but I do think that it's both, because type 2 diabetes is the factors, the environmental factors as well as genetic factors that come into it. And I do think that where they work and their sedentary lifestyles, working in an office, or even the genetics that do cause a higher risk for them to be at higher risk for type 2 diabetes.
Any other questions for Anam? Right? Dr. Bain an opportunity to say a few words as your school.
So I first met Anam in the fall of 2020. Yes, online. We're all online. I know, it seems like just yesterday. But she was in an epidemiology class, and the students got to do a project where they chose a population and they chose a health outcome, and they analyzed it, and then they suggested solutions. And it was like really obnoxious, so I changed it after that to make it not so obnoxious. But the topic that Anam chose was, the population was China, and the topic was diabetes. And I only asked for one solution, and she gave me 3. And so, needless to say, she did very well on that assignment. And so I could see immediately that she has just this very strong wanting to help the community be healthier. And so it's no shock that she's planning to pursue medicine after she takes a gap year. She's the first generation college graduate, and so she's an amazing role model for all of her family. She has a lot of family still back in Pakistan, and so especially for a woman to be a college graduate is really an inspiration. And so I'm really looking forward to her staying in touch and telling me all the successes that she has in the future and inspiring our future.